Before I start my talk, throughout the morning I've been sitting and we've been facing a lot of controversies and various issues. And I remembered a quotation which I thought was very apt, that when we do our MBBS, we think we know everything. And when we do our MD, we realize we know nothing. And when we do our masters, we realize we know nothing, but so do everyone else. Everybody else also knows nothing. And that's exactly what's happening. Just because I'm standing here does not mean that there's something additional that we know. Medicine is a field in which everything goes on in a circle. I remember the time when HIV came out and we were starting ART, and the first mantra of ART was hit early, hit hard. So everybody who was diagnosed as HIV would be started on treatment. Then came various research and said, CD4 less than 200, start treatment. Not before that. Then came a research and said, no, 350 should be the cutoff. Then the research came and said, 500 should be the cutoff. And now we are back to an era of saying hit early, hit hard. So we come back to a full circle. Similar way in the morning that we had, steroids or no steroids. CSF to be done in miliary TB or not to be done. It's all a controversy. Nobody is wrong. Everybody is correct in their own right. It's just that as more and more research comes, we become more and more confused. When we look at a meta-analysis, when I look at meta-analysis, I look at those lines. Some lines this side, some lines that side about various studies. And based on those lines, whichever is more on which side, a conclusion is drawn on a meta-analysis. The same thing as a Cochrane review will give me a different conclusion. And at the end, I say this is evidence-based medicine because I went through the guidelines which said strong recommendation based on poor clinical evidence. Okay, and that's what we are going to come to the various guidelines in WHO recently. So what I want to talk here today is more of based on personal experience. Because I think, why are we having so much dispute? Why are these randomized control trials not reproducing the same results everywhere? Is because everybody has their own different epidemiology. Everybody has their own different genetic population to which they are catering. And similarly, it's the scenario in TB. What may be true for Mumbai may not be true for Bangalore, may not be true for Delhi, may not be true at all for the developed world. So we need to have our own research in place to tell us what to do. Drug-resistant TB, we all know various definitions: monoresistance, one drug; polyresistance, two drug; MDR, when you have resistance to INH rifampicin, that's the backbone of your TB. XDR TB is when you have MDR plus a fluoroquinolone plus an aminoglycoside. And now we have a new term which is based on the Genexpert, which picks up rifampicin resistance. So if you have any patient who's rifampicin resistance on Genexpert, it's known as RR. This rifampicin resistance could be isolated rifampicin resistance, it could be an MDR strain, it could be a polyresistant strain, it could be anything. So till we get more DST reports on the cultures, the patient is labeled as having an RR strain. About MDR TB, treatment currently is very long. It's absolutely probably 1.5 to 2 years therapy. Very toxic therapy, a lot of side effects. If you're not in the program, it's an extremely expensive therapy. And out of that, global data says that only half of them are going to complete their treatment. Remaining, those who have not completed treatment, either they are lost to follow-up, they've died, or they've just stopped the drugs because of the side effects or the cost. 2013 is the latest data that I could get from WHO. 480,000 cases with MDR globally, out of which 9% had XDR. And half of these patients are in India, China, and Russia. So we are at an epidemic of MDR TB in the country. If you look at TB India, what we see, this line tells us that the prevalence of TB has actually gone down. So you'll find a lot of doctors coming and telling me, I hardly see TB. Yeah, because TB is going down, but what is going up is the MDR. The MDR prevalence has really gone up. In the community, it's around 2.2%. And out of 248,000 official figures in India that were treated in 2013, 35,000 were MDR TB, or the rifampicin resistant strains. How does this resistance occur? Either you are infected by a resistant bug right away. That's what is the resistance pattern in children. They are not going to have secondary resistance. They are usually going to have primary resistance. Secondary resistance occurs when somebody is treated with an inadequate regimen, does not take the treatment properly, Or you've given so many drugs that there is malabsorption, drug-drug interactions, and that is the problem that has led to a secondary resistance. How do you pick up secondary resistance? Patient was sensitive to the first line initially. While on therapy, he became resistant. What are the risk factors of having drug-resistant TB? Either you're exposed to a patient who has drug-resistant TB, you're exposed to a patient who's failing his treatment or who is relapsing on his treatment, you're exposed to a person who's living in an area that is endemic for MDR TB, or you are exposed to a patient who continues to remain AFB positive in spite of 2 months of intensive phase. So these are your markers that tells you that this patient could be having drug-resistant TB and the child should be screened for drug-resistant TB. Treatment of drug-resistant TB is hardly empirical. It's always evidence-based. You need to prove it because you're going to give aminoglycosides. You're going to give injections which children hate to take, and you're going to give them for at least 6 to 8 months. You're going to give them a lot of toxic drugs. So you need to be sure, absolutely sure, that you're dealing with drug-resistant TB. You cannot start treatment of drug-resistant TB empirically. There are 2 ways of diagnosing them. One is a phenotypic assay. That's the regular disc diffusion method that we do. We grow the organism on a culture. We put the tablets or the medicines in the disc, and we look for the diffusion. So that's how we look at the phenotypic DST. The problem with the phenotypic DST, it's going to be done only after a culture. Your culture is going to take 3 to 6 weeks, depending on liquid media or solid media. You do a DST after the culture grows an organism, so that's another 15 days. So it's a little longer time that takes place. So you have these genotypic DSTs, that's your nucleic acid amplification test, the NATs, which can detect mutations. So you look for an RPO gene mutation for rifampicin, you look at an INHA gene mutation, or you look at a CAT gene mutation for INH. So you look at mutations. Advantage is you get the results in a matter of hours to in a matter of days, probably in 72 hours. WHO came out with a recommendation on Genexpert, and we've heard a lot about Genexpert recently. It recommends use of Xpert as the initial diagnostic test rather than microscopic culture and DST. So it's the preferred test now in all patients with TB. Earlier it used to be in patients suspected of MDR TB. The latest guidelines mention you do it in all patients with TB. And it's a very easy test. You and I can do this test. We don't need a microbiologist for this. It's an automated PCR machine. It comes with a cartridge. You take the sputum sample or whichever sample, put it in the cartridge, put it in the machine. The machine gives you a reading in 2 hours. So it's not something that is requiring any expertise on this. Now WHO, when I went through the guideline, this recommendation is based on a lot of adult data. We don't really have children data from India, especially from India. We would have a lot of data from South Africa because that's another hub of MDR TB. But we really don't have data on Genexpert from India. This is our experience that we've had. It's still unpublished data. We've had 34 children with clinically diagnosed TB. Now we have diagnosis of TB based on clinical diagnosis or bacteriological diagnosis. So these were patients who were diagnosed clinically based on imaging, suggestive histology, or where available a positive history or a tuberculin test. Now, if we take these 34 patients, what we had is 20 patients were Genexpert positive. So we had a sensitivity of Genexpert to be around 58%. We could do cultures only in 28 patients. In 4, it was not done, and in 2, the results are still being awaited. So this study is still ongoing. However, of those 28 patients in which we did a culture, we had 18 who had positive cultures. So we had a yield from a sensitivity from a culture of the tune of 64.2%. So slightly better as compared to Genexpert. Resistance, that is rifampicin resistance identified by Genexpert, was 55%. Out of those 18 who we had a culture positive, we have got the results in 11. In 5, the DST reports are still pending. This is the data that I've removed on Thursday. And in 2, we've not done a DST. So out of the 11 that we've got the DST, 8 were having drug resistance. So we picked up 72% having drug resistance. So to pick up drug resistance, we were having a culture which was better. And what kind of drug resistance? Genexpert only picked up rifampicin, whereas the DSTs helped us to pick up a lot of drug resistance, including the second line. And the commonest kind of drug resistance that we were seeing is isoniazid, rifampicin, pyrazinamide, ethambutol, streptomycin, quinolones, moxiflox, oflox, ethionamide. That's the kind of resistance. Now, if I have a child in a program and I'm going to go on a child who's going to go onto an aminoglycoside, quinolones, pyrazinamide and 2 drugs, of which if I take this particular resistance pattern in Mumbai, I would be having a child who started on the program on a second line, but receiving drugs that are only 2 or 3 drugs that are sensitive, and not all of them. So when I'm treating MDR, for me, Genexpert is not enough. I need to have the DST reports. If we consider how reliable is Genexpert and MTB culture when taken together, out of those 20 Genexpert patients who were positive, we could do cultures in 18 and 15 were positive. So culture didn't pick up the other 2 Genexperts. But what was important was, where we had Genexperts negative, we still had cultures positive. So Genexpert is not 100% sensitive. Okay, we still pick up cultures. So both are not enough. Doing a single test is not enough. What we concluded is this: we need to do Genexpert, we need to do a culture. Either one of them is not enough. So though WHO recommends to us saying that it's the preferred test, Genexpert, as the initial, what I would say is we need to do both. If we look at the specimens that we send, when we look at sputum, Genexpert and AFB smear was the same. So we had no advantage of Genexpert in the sputum except to pick up rifampicin resistance. Culture was 100%. What was important is in CSF. CSF Genexpert was slightly better as compared to the cultures. The other places, we did have serosal fluid, we had cultures which were better. Biopsies, that is your lymph node biopsies or wherever we've taken biopsies from extrapulmonary site, the cultures were much better as compared to Genexpert. So Genexpert does come with a caveat. It's not as good as it is being projected. Yes, it's very fast. You're going to get your results in a matter of hours, but you need to do cultures simultaneously. So we concluded that sensitivity of culture is slightly better than Genexpert for bacteriological confirmation. Resistance yield is better with MTB. You can pick up first and second line. Yield of Genexpert is slightly better with CSF. Other extrapulmonary samples, culture is better. So we conclude that Genexpert alone cannot be used for diagnosis of TB. You need to do both cultures and Genexpert. And identification of the type of drug resistance is important because you need to pick up MDR with other resistance, pre-XDR and XDR. That cannot be done with Genexpert. Now, is Genexpert the only assay that we could do? Are there other nucleic acid tests that we could do? Yes, we've got these line probe assays, which are based on the same PCR test, but these line probe assays can also check for INH. You have various companies that make these line probe assays. So you can also check for INH. You can also check for second lines. So you can check for ethambutol, fluoroquinolones, capreomycin, amikacin, kanamycin, all these drugs. The thing is, it's costly. It's going to be extremely costly. We've done it in a few patients and we find it really, really costly, but it correlates with the DST reports. So it's not that bad a test. So if you do have a child who's 2+ or 3+ AFB smear positive and you're strongly suspecting drug-resistant TB, you could do these line probe assays and get your resistance pattern much earlier as compared to a regular conventional culture and DST. The phenotypic DSTs, the disk diffusion methods that I told you, also comes with problems. We had a big scenario in Mumbai when a term called as TDR TB was proclaimed in the papers. And there was a big hue and cry, and the central TB team had come down and said, we don't endorse the term TDR, and we said this term is XDR. And the group that had published the data said that whatever drugs we tested were actually resistant. So WHO said, if you look at the phenotypic assay, rifampicin INH, 100% reliable. But if you do DSTs for streptomycin, ethambutol, pyrazinamide, in vitro, in vivo data is going to differ. Similarly, for second-line DSTs, for injectables and quinolones, reliable. But if you're going to do for, say, PAS, ethionamide, cycloserine, you don't know. So based on DST reports, you still won't be able to say this is a TDR patient. At the most, you'll be able to say XDR. There's a lot of cross-resistance between resistance. So if you have rifampicin resistance, don't use rifabutin or rifamycin. It's not going to work. If you have INH resistance, you must look whether there is INHA gene resistance, because if it is there, ethionamide cannot be used. If you have amikacin, probably kanamycin cannot be working. So you have cross-resistance between a lot of drugs. You have groups of quinolones, which are generations of quinolones that you have to decide. So how do you decide you're going to use levoflox, oflox, or moxiflox? That depends on the generation. If the child is resistant to oflox, will the moxiflox work? Yes, it will work. So you have these generations. Now this was the initial preliminary data that we had published in 2012. 500 children, 6.8% had drug-resistant TB. What we've further analyzed is over a period of time whether this drug-resistant TB pattern has changed. And what we found, incidence has remained the same, 5.6%, 7%. Pattern, yes. MDR percentage has gone down, though the number of patients did go up because we started seeing more and more drug-resistant TB. What happened is XDR came up. We hardly had XDR in the initial years, and now we started seeing XDR TBs. That means the kind of resistance that is changing is becoming more and more drugs that are becoming resistance, including our pre-XDRs. And the kind of resistance, this is the most important slide that I wanted to show you. We've all been talking about Genexpert and rifampicin resistance. When you have rifampicin resistance, you have INH 100%. And that's what's being shown here. So when you have rifampicin, INH, we're seeing increasing resistance to pyrazinamide, ethambutol, streptomycin. So this is what is there in Mumbai already. So if I see this pattern, I know none of these are going to work. What is additional coming up is ethionamide resistance, which was not there earlier, and resistance to moxifloxacin, which is not there earlier. So now I'm actually seeing pre-XDR. I'm not talking about only MDR, we are talking about pre-XDR now. Now when we talk about treatment of MDR TB, lots of drugs have been classified. You have group 1 drugs, which are bactericidal, so you have HRZE. Streptomycin initially used to be included in group 1, but now streptomycin is considered as part group 2, which is your injectables. So streptomycin, amikacin, kanamycin, capreomycin. Group 3 are your quinolones. Generations, you have Oflox, which is no longer recommended as TB treatment nowadays. Levofloxacin, moxifloxacin, gatifloxacin. In fact, before gatifloxacin was banned because of the issues of diabetes, we had used it in a couple of patients and we had found excellent results with gatifloxacin. Group 4 are your oral bacteriostatic drugs. You can use any 2 of the groups. So you have ethionamide or prothionamide, cycloserine, and PAS. Group 5, luckily we've had now newer drugs that have now come in, the bedaquiline and the delaminate. Both are used only in adults currently, not recommended in children because we don't have any safety data in children, nor do we have any pharmacokinetic data in children. Linozolid, clofazimine, amoxiclav, imipenem, meropenem, high-dose isoniazid, that's 20 mg per kg, clarithromycin. These are drugs with efficacy in vitro. How they work in vivo, we do not know. We have used a lot of linozolid and clofazimine in our patients, and I'll show you little data on that. MDR treatment also contains an intensive phase and a consolidation phase. The intensive phase actually contains an aminoglycoside, plus pyrazinamide, plus at least 4 second line, plus the other 2 drugs that you need to give. So you need to give at least 4 plus an injectable. And when you continue with pyrazinamide, quinolone, ethionamide, PAS, whatever you're giving in these patients. Treatment duration, earlier when WHO came out with the recommendation, it said intensive phase for 6 months, now it says 8 months. You could prolong it or decrease it based on your patient's response. Earlier the recommendation for MDR was 18 months, now the recommendation is 20 months therapy. And before you stop therapy, you are actually supposed to document either a cure or a treatment completion. For XDR TB, because you may have quinolone resistance and you may have aminoglycoside resistance, you could still try an aminoglycoside which you've not used earlier, that is what WHO recommends, or you try to use a regimen in which you don't use an aminoglycoside or a quinolone, but you go on to group 5 drugs, the newer ones that are there. XDR treatment is probably 12 months with an injectable, intensive phase, and at least 24 months the total therapy. And when do you stop? You don't stop because the child has completed 18 months or 22 months. You're going to stop therapy, either you document a cure, that means at least 3 cultures negative. Or if you can't do that, especially in children, it's very difficult to document a cure, then you should have at least treatment completed where you completed the total duration of therapy, you documented a clinical and a radiological improvement, and there's no relapse. That's the time you would say treatment completed. Treatment failed is somebody who didn't convert, still remained positive after intensive phase, or the bacteria came back in the continuation phase, or you develop additional resistance while the therapy was going on, or the child developed adverse effects. Then you call it as treatment failure. And loss to follow-up, anybody who's not coming to your clinic for 2 months is known as loss to follow-up. For monitoring bacteriological, when you're monitoring, you're supposed to monitor cultures and sputum. You're not supposed to monitor the Genexpert or the nucleic acid test. Just a little bit about bedaquiline, bactericidal drug, used in adults 400 milligram once a day for 2 weeks, followed by 200 milligram 3 times a week for 22 weeks. The problem is QT prolongation, and it has a lot of P420 enzyme induction, so you use it carefully with rifampicin or other drugs. Delamanid, recently recommended in adults, especially only for pulmonary MTB. So again, conditional recommendation, very low confidence in estimates of effect. So you have controversial, I don't know how do you interpret this statement. So again, they say do not use it in patients with QT prolongation. Both these drugs are not yet recommended in children. There is no data, again, whether we should use simultaneously both these drugs in the same patient. So we've got new drugs that have come out for TB treatment, MDR TB, but at the same time, we don't know whether they're going to actually work in children and whether they're going to keep these patients alive. Problems with treatment of MDR TB, pill burden. When you are giving PAS, either you're giving PAS in the form of a granule or you're giving PAS in the form of a tablets, you're almost giving 3 to 4 tablets of just PAS, then ethionamide, cycloserine. Cycloserine is available as a capsule. When you want to give it as a capsule in a child, I have to get it pulverized. Only one pharmaceutical is making it as a tablet, but the cost really goes up. Clofazimine is available as an oil-based capsule. So if I want to give 10 milligram from a clofazimine capsule, which is 50 milligram, I have to open the capsule, dissolve it in oil, and tell them to take 1 ml. So there are issues about all this. So the compliance becomes a problem. Because to get your parent to be compliant to this kind of therapy is really going to be an issue. Cost. Standard cost for a 10 kilo child on second line AKT is going to be 5,000 to 6,000 per month. I'm talking about a 10 kilo child. So if you're talking about heavier children, it's going to be even much more. So if you're not in the program, and a lot of kids, a lot of parents don't want to be in the program. They don't want to go to the center to collect medicines. They want to take the medicines on their own. Then this is the problem that they're going to face. And the problems of the side effects. Immense side effects. Plenty of side effects. We did a study on aminoglycosides and toxicity. We analyzed 84 patients with drug-resistant TB. This data is till 2013. And 84, out of these 84 children, 67 had received aminoglycosides. Mean duration was almost 6 months in most of the patients. 31% had hearing loss while we were screening them. Mind you, none of them had clinical hearing loss. So symptomatic hearing loss was 0. All of them were detected to have hearing loss on regular screening. And what kind of hearing loss we found was predominantly sensory neural deafness, and mainly at high frequency. So that's the reason we didn't pick up clinical. So we were able to stop the aminoglycosides before they could have a clinical hearing loss. So pretty high side effect. I mean, 31% having ototoxicity. Nephrotoxicity we found in 14%. All of them responded by just dose reduction. So we were not really worried about the creatinine going up or the electrolytes going haywire. The kind of aminoglycosides that we use predominantly amikacin. We use kanamycin in a few patients. Capreomycin, we don't really use it in children. Then you could have certain different kinds of side effects. Now this was a girl who came to my clinic and she was an MDR TB. I had stopped her multivitamins a month back. She came back with this kind of dermatitis over the hand. And this was ethionamide induced pellagra. And we just stopped her ethionamide and started her on nicotinamide. And after 15 days, the dermatitis responded. Now when I went through literature, there were hardly 3 cases reported of pellagra induced, ethionamide induced pellagra. So what we earlier used to thought, okay, AKT means only AKT and not multivitamins. I started, after this case, okay, everybody should be on a multivitamin. So there are issues that are there, especially vitamin D is another issue of tuberculosis, which I think will require another session on just vitamin D and tuberculosis. Then there are issues of hypothyroidism. You actually pick up subclinical hypothyroidism. We never had any patient with clinical hypothyroidism. But especially when you're giving a combination of PAS and ethionamide, you are going to have these problems of subclinical hypothyroidism. So this is a combination you try and avoid as far as possible. If nothing, you need to give these combinations together, then give it, but then monitor for hypothyroidism. 53% of our patients who had received both these drugs had subclinical hypothyroidism, and mean duration was around after 6 months of therapy. Linozolid. Linozolid is a wonderful drug. And I would say that because leave this drug alone, don't use it for community-acquired pneumonias. There are only two conditions in which you need to use linezolid. One is a VRSA, vancomycin-resistant Staph aureus, and the second is MDR TB. Not even MDR, pre-XDR or an XDR TB. So don't use up this drug for community-acquired pneumonias. When we are talking about rational antibiotic policy, I think we should have this, that linezolid should not be available just like that. It should be only kept for two conditions. Now, out of our 84 patients that we had found, 20 had received linezolid. We didn't see any patient getting optic neuritis. We didn't see any patient getting granulocytopenia. In literature, when you go through literature, you'll find that a lot of literature says that you need to monitor their CBCs if you finish 28 days of linezolid. We didn't find that, but we did find tingling numbness in a few. We did find anemia. We did find liver enzymes elevated. But nothing that really required us to stop the drug. We just had to go on a dose reduction, and that's it. So drug-resistant TB is on the rise. There are only two novel drugs, bedaquiline and delaminid, still not recommended in children. Pre-XDR and XDR are coming up issues. Drug adverse effects are a great challenge, and outcome still remains guarded in these patients.